and welcome to the APAP podcast, the official podcast of the Association of Pulmonary Advanced Practice Providers, where we're exploring the latest in pulmonary medicine from the perspective of those delivering care on the front lines. I'm your host, Corinne Young, president of APAP, and today's episode dives into a topic that's becoming increasingly critical in interstitial lung disease clinics, screening for pulmonary hypertension. As ILD care grows, more nuanced, early recognition of PH can have a meaningful impact on patient outcomes. So joining me today is Jessica Glennie, an esteemed member of APAP and faculty for our conference as well. She's an expert in interstitial lung disease. Jessica, for those of you who don't know you already, would you mind just giving us an introduction on yourself?
Absolutely. Thanks, Corinne. So wonderful to be here with you. I'm Jessica Glennie. I'm a nurse practitioner at the Cleveland Clinic in Cleveland, Ohio. I work specifically with the interstitial lung disease team there and have a special interest in connective tissue disease and interstitial lung disease, which many of our viewers may know involves a lot of pulmonary hypertension. So this is right up my alley. So thanks for having me.
Of course, thank you. All right, so together we're going to try to unpack some real-world strategies, clinical pearls, and practical considerations to enhance screening efforts in our listeners' practices. So our first question for you is starting with the big picture. It's always good to put things into context. So why is screening for pulmonary hypertension so important in ILD patients?
Yeah, great question. So for interstitial lung disease patients, we certainly know that these patients, they already have a lot of struggles with a lot of different symptoms. They're dealing with shortness of breath, fatigue, hypoxemia, and these patients have a poor survival. We know that patients with interstitial lung disease are at higher risk for pulmonary hypertension because of the underlying disease and changes that occur to the pulmonary vasculature and destruction of the pulmonary vasculature in interstitial lung diseases. So this puts them at higher risk of developing pulmonary hypertension, which itself we know has poor outcomes and poor survival. So when you combine these two together, you have patients that are really burdened with a lot of symptoms, but also have increasingly poor survival when you have both of these together. And now with a new strategy, new medication to manage these patients, it's so important to find those patients.
I agree. I think that initially it was kind of a second thought when they start developing pulmonary hypertension. We're like, dang, now what are we going to do for them? Now that we have treatment options, it definitely is, I think, a little more front of mind to think, oh, maybe we should also screen for this at the same time now that we can do something about it, right?
Yeah, absolutely. It's been a real game changer. Before, if you don't have much that you can do for them, why continue on with screening and right heart cath and things like that if you don't have anything to offer them? So absolutely.
Yeah. So when you're trying to decide among your ILD patients, which ones warrant further evaluation for pH, are there any specific risk factors or red flags that jump out to you to say, okay, this patient needs the pH portion of workup?
Yeah, absolutely. So when I'm seeing patients, I can start to kind of risk stratify them even before I talk to them about their symptoms or look at any of the diagnostics. So, I talked a little earlier about how I have a passion for these connective tissue disease patients. So those patients in particular can have a higher risk of pulmonary hypertension. They can get PAH group 1 pulmonary hypertension as well as group 3, which is pulmonary hypertension related to their interstitial lung disease. In particular, are scleroderma patients. They have about a 10 to 12% risk of pulmonary hypertension over the course of their diagnosis. So we definitely want to keep that in the back of our minds. What type of what type of interstitial lung disease do they have? I can also think about, my patient, are they a patient that has very mild disease or very severe interstitial lung disease? While we can see pulmonary hypertension in patients earlier on in their disease with mild disease, we do know that as pulmonary fibrosis gets worse, we have higher risk of pulmonary hypertension. So if there's a lot of advanced fibrosis, I already know they're at a little bit higher risk of pulmonary hypertension. And then a lot of those signs and symptoms, they are very similar for both ILD and pulmonary hypertension. So it can be difficult. So that shortness of breath, fatigue, Um, but if I'm starting to see that that's out of proportion to their interstitial lung disease, their shortness of breath, their oxygen demands, their amount of fatigue, things like that will definitely make me think a little bit more about pH. And then, of course, symptom wise or signs wise, if you're seeing signs of right heart failure, so jugular venous distension, you're seeing peripheral edema, you're seeing you're listening to your heart sounds and they have like a loud P2, things like that are very specific to some signs of right-sided heart failure.
So, what does that screening process look like to you once you say, okay, this patient's raised enough red flags or has enough symptoms that concerns me? What does the workup look like for you?
Yeah. So a lot of the diagnostic workup that we often do for our patients every time they come in for ILD, whether we're thinking of pH or not, really can help us. So for all of my patients, pretty much every time I see them, I'm getting a spirometry and a diffusion capacity. I'm oftentimes getting a 6-minute walk or a ambulatory oximetry. And then sometimes I'm getting a CAT scan. And all of these diagnostics can really help me to kind of parse out what patient I think is more at risk for pH. So, for example, with our pulmonary function testing, I really look at that diffusion capacity because we know that if that diffusion capacity is quite low, below 40%, if it's dropped a lot since the last time I saw the patient, more than 15%, and especially if that diffusion capacity is very low and our FVC, which is kind of a way for us to gauge, the severity of their interstitial lung disease. If those are very disparate, if those are very far apart, we have a pretty mild or pretty well preserved FEC, but a very low DLCO. Those tell us something else might be going on. Um, we look also at that walk test, that exercise capacity. Has their exercise capacity really dropped off? Can they not walk, as far as they did last time? Are they requiring a lot more oxygen? Oxygen is something that patients with ILD need, but if I see a big change in their oxygen requirements, I am starting to think about pulmonary hypertension. Um, and then some signs on our CAT scan. We can look at our CAT scan and maybe a radiologist has said, that pulmonary artery looks a little bit enlarged. That right ventricle looks a little bit enlarged. Um, there are different ratios of the PA to the aorta. The PA to aorta ratio is greater than 1. Or sometimes you'll see your radiologist say it's measured greater than 3.2 centimeters. That's a sign that your PA is enlarged and maybe start thinking about pulmonary hypertension.
Yeah, those are all things we look for. I think that was a great review.
Yeah.
I know when patients are coming to you at a high-end clinic, like where you work, just focusing on ILD patients, which now you have to be a vascular person too with pulmonary hypertension. Um, what are the barriers or the challenges that you think are keeping a lot of your patients from being screened out in the community for PH-ILD or pulmonary hypertension in ILD patients?
Yeah. I think some of it is just not awareness of pulmonary hypertension, ILD, and kind of what to look for. Um, you know, uh, uh, Sometimes we may not have as much resources as we need as well. So maybe we only have a certain number of slots for echoes, in the coming week, or it's really hard to get a patient in for an echo. Um, there may be some misconceptions of right heart caths that, maybe they're dangerous for patients, or maybe we don't have somebody who we can reliably send to for right heart caths for these patients. So I think these can be a lot of the kind of the big barriers to getting patients assessed for pulmonary hypertension.
Do you feel like patients need a right heart cath before coming to you, or do you feel like they could just start with the basics of just screening with an echo, the CT scan imaging, and the lung function? Do you feel like that's enough?
Yeah, absolutely. I think for most patients, that's enough. We would probably start with, your kind of your bread and butter, let's say IPF, ILD patient. We would probably get a few things, the CAT scan, see if we see any signs on that, the PFTs that I talked about. We can also add on what's a biologic marker called the NT-proBNP or the BNP, which is just a sign of stress on that right ventricle. If that's elevated, that can be another sign that there's pulmonary hypertension. And then that echo is key. So we haven't talked much about the echo yet, but that's our big screening thing that we do. If we really have some concern that there's some pulmonary hypertension, an echo is really your next best screening.
Yeah. Well, why don't we talk about echo now, if that's
Yeah,
okay with
yeah,
you? What are the key markers that you're looking for on an echo?
yeah, yeah. So when we're looking at our echoes, one thing we're looking at is that right ventricle. So pulmonary hypertension really affects the right side of the heart. And the right side of the heart really doesn't, can't put up with these high pressures over time the way the left side of the heart can. It's a little bit more puny. So you'll start to see, especially if a patient has had pulmonary hypertension at a, moderate level over a period of time, that right ventricle may become dilated and you may see impairment of the function of the right ventricle. We can also look at some other measurements. So the right ventricular systolic pressure, we can sometimes get an estimate of that. Generally, if it's over 35 millimeters mercury, that is indicative of pulmonary hypertension, and the higher it is, the more concerning for pulmonary hypertension. There are some other measurements that your cardiologist might put on your report, something called TAPSE, tricuspid annular plane systolic excursion. This is just looking at this is just looking at how much the annulus of the tricuspid valve moves during systole. Now, it should move a good amount if you have a good functioning right ventricle. But if it's not as strong as it should be, that could be a sign of pulmonary hypertension. And then sometimes if that right ventricle is very dilated and there's a lot of pressure, you can see that the septum, intraseptal area of the heart will be flattened. So that pressure is kind of pushing that septum towards the left side of the heart.
Yeah, the left side starts definitely get impacted. All
Yeah.
right. Well, that was a great review. And TAPSE, oftentimes, 9 times out of 10, if a patient asks me what TAPSE stands for, I really struggle with that. So great job pulling that out of your hat there. All right. So looking towards the future, how do you see things changing in this realm of pulmonary hypertension involving our interstitial lung disease patients? Do you think there are new emerging therapies, diagnostics, things like that that might help us better identify and treat these patients?
Yeah, absolutely. So, I think that this has already started, that we have started screening more for pulmonary hypertension patients in our ILD realm, just because now we have a medication that's approved for treatment of these patients. So we have inhaled treprostinil, which has been a medication that has been used for PH for many years and has since been approved for group 3 PH-ILD in particular. So I think the needle is already moved. We're already starting to screen these patients more. I think that this has put some hunger out there for more therapies to be developed. I have heard, that there has been one more therapy, like an inhaled therapy, that may be looked at in this realm in PH-ILD. So I think we've just hit the surface, though. I think that we'll see more innovation. Yeah, absolutely, as time goes.
I'm really excited about AI, and I'm hoping AI comes into play in the echo readings because, I mean, how many echoes do we get that we don't get a pulmonary artery systolic pressure measurement or RBSP? We don't get, TAPSE a lot of times, depending on who's reading that echo. But how great would that be if you could run that imaging through AI and maybe get some of those measurements we don't always get? Maybe even
I
while they're
think it's coming.
while they're doing the
Yeah,
procedure, we can maybe call out. I think AI may play a big role here too, because we know
yeah,
there is already discussion about AI interpreting CAT scans, right?
yeah, yeah,
So maybe it'll also pull out, hey, pulmonary artery is also enlarged, right ventricle looks enlarged, in addition to all your reticulations and fibrosis and other things that you're seeing on the CAT scan, right?
Yeah, I think we're just starting to get into a new fun age of AI in healthcare. I think it's going to be a help, not a hindrance. It's not going to replace a radiologist, not going to replace the clinicians, but a really great tool. And I think it's going to be really amazing for those more rural areas that might not have a good thoracic radiologist reading these scans. So yeah, I think I'm excited about that too, Corinne.
Yep. All right. Well, that brings us to the end of this episode. Huge thank you to you, Jessica, for sharing your insights and wisdom on screening these patients with interstitial lung disease for pulmonary hypertension. And it's, I think, again, a very important topic. The needle's definitely moving. We've never had a group 3 pulmonary hypertension therapy before at all. And now we have one specifically for ILD patients that have pulmonary hypertension. So that's very exciting. So, any last words or any other comments you'd like our listeners to know or think about when they're seeing these patients?
I would say, if you're seeing a patient and you're really, feeling like this patient could have pulmonary hypertension, please just get an NT-proBNP or a BNP, whatever your facility has, and an echo. Do the screening. They're pretty simple screenings to do. They're non-invasive. So just start with that.
Excellent. Well, thank you so much again. Thank you to our listeners for listening to this episode. If you enjoyed the conversation, be sure to like, subscribe, and follow our podcast. You can also stay connected with us through our website at pulmapp.com. You can follow us on all the social media channels as well. And don't forget to download the APAP ACE mobile app on all the app stores. You can find them there. And again, thank you for listening, and we'll talk to you next time on our next podcast.